This is a family having their baby at home, and what you don't normally see is you've got the dad in the pool and you've got her toddler in the pool as well after the baby's been born. That to them was very normal and a very happy occasion, but I challenge anyone to say that is a normal way that we see now of women having babies. So I'm talking about the most common way of having a baby. But this is just a video made by a journalist, and it's on YouTube. You've got the link there. And all it's showing really, in the middle of it, I was just going to show you a woman who's at home hypnobirthing her baby with very, very minimal medical intervention, but it's very safe. The baby's born very healthily. And if you're not used to seeing babies born in that way, then it will actually look quite alien to you. You just will not associate that is a way to have a baby. So have a look at the link if you get chance. Normal birth rates, you could actually argue that we even spent a time looking at the South West London definition, but what it generally is interpreted as is no induction of labour, so no use of prostaglandin, syntocinon or induction with ARM, no epidural or spinal, no GA, general anaesthetics, no instruments used, no caesarean section, and not an episiotomy either. So that's the general definition of normal birth, as Birth Choice UK will demonstrate if you look at their site. And that's pretty much what we've used in our dashboard as well as to what is normal births. So it's different to measuring spontaneous vaginal births. We're talking about something different. And if you look at the graphs here, again, this is off Birth Choice UK website, you'll see that one's the normal birth rate and one's the caesarean section rate. And I won't go into the percentages there, but you can actually tell without actually knowing very much which one's the caesarean section rate and which one's the normal birth rate. Clearly, the caesarean section rate is rising and the normal birth rate is generally falling. Again, off Birth Choice UK site, they actually have all the data for all the trusts in the UK, or certainly for England, Wales, Scotland and Northern Ireland. And it's quite interesting to see the trusts that have the highest caesarean section rates. All of them in London, on the left there. And then if you compare to those that have the lowest rates in the country, all out of London, and you can look at the lowest one in the country, which is the Royal Shrewsbury Hospital, with a 16.4% caesarean section rate. One's in Cornwall, one's in Scunthorpe, the other one in Nottinghamshire. The only thing I can see on paper, just looking at those figures quite crudely, is that they have got midwifery-led units within those centres. They've got midwifery-led units within some of those London hospitals. But again, I think we need to look at what is actually happening in our midwifery-led units within our trusts in South West London. How are the women giving birth, and how is the midwifery care being given? This isn't my area of expertise, but I just wanted to throw this into the session really, because it's something that you don't hear spoken about very much. But the way that babies are being born now is possibly in many years to come going to affect even their DNA, their immune response, so more common diseases like asthma, eczema, even childhood obesity. Some of these things are being linked with the way the babies are born. And I've only ever heard, interestingly, paediatricians or neonatologists talking about this. I've never heard it come through an obstetric angle. But for those babies born by caesarean, what is being noticed from an immune response is that they're not being exposed to the normal bacteria that are present following vaginal birth. They're not being colonised with those organisms. Hence, they're having a difference in their immune system when they become children. And also, if you have no labour and certainly lower breastfeeding rates, you don't get that colonisation in those babies either. So we're talking longer term problems in babies and children, not just about the way that the baby's born and the effect it had on the mother. The epigenetics is fairly new and it's not really concluded yet, and it would take a lot more research, but babies that undergo labour, they go through a stress response, and that's being thought to change their DNA. Babies born by caesarean, and I'm talking planned caesarean where there hasn't really been much of a labour, potentially they could have altered DNA. And again, I'm not an expert on this and I wouldn't claim to be, but those children, there's potentially going to be a link again with autoimmune disease and children that are born via elective caesarean section route. I know this is an emotive title, Women in Stirrups. This is actually something that I found from one of the lecturers that was produced and followed on from a woman who'd had her own children and became a student midwife. And during her diary, if you like, of what she was seeing within labour wards was actually quite frightening to her. And she made a film about it. But we're trying, it feels, to help women have normal births, and we've got all the reports that came out through Changing Childbirth, National Service Framework and the Maternity Matters report, but we're not actually making that much of a difference at the moment. Women are still not having those normal births that they perhaps were having, and I know there's an increase in obesity rate. We know that women are getting older having babies, but nonetheless you're still seeing very different differences in certainly the caesarean section rates and the normal birth rates across the country, and you can't just always put that down to the demographics of the women. Interestingly, when I've audited before, because a lot of you will know me, I've worked in most of the trusts of the sector, auditing things like perineal trauma rates, you were finding just by looking at notes, women were in a lithotomy position to give birth. There was nothing in the notes to suggest why that woman was put in that position at all, and that is what we're talking about when midwives, for some unknown reason, are using lithotomy positions to, I suppose in their view, help the woman give birth vaginally, but actually doesn't improve normal birth rates. So we're almost on two spectrums really. We've got completely normal physiological birth, and then we've got a very technical approach to birth, and normality fits all the way along the spectrum there, because we're not just talking about women who give birth in the midwifery-led units, we're also talking about those women who are within the labour ward settings as well. I think you'll find that most of the evidence shows you that it was good intentions in trying to reduce perinatal morbidity rates that's ended up with a higher section rate and a higher instrumental rate, but it actually hasn't at the end of the day improved a lot of perinatal outcomes for babies. What we seem to need, and I think we sort of pay a bit of lip service to it at the moment, is that really good dialogue between our women that use the service and their families, the GPs, the obstetricians, the midwives, to actually improve normal birth rates. And we don't come together very well. I don't think we come together even as obstetricians and midwives, let alone people that are using and providing the service as well. If you look at places at the moment that are really trying to give women the information about birthplace choices, there's some interesting work going on, and we mentioned it, the work with Kingston, how they market their midwifery-led unit. Portsmouth have come out with quite an interesting app about birthplace choices to explain to women the risks, if you like, of having a baby in an obstetric unit, and in terms of then having it at home or in a midwifery-led alongside birth centre. And then if you go to Barnet, they have a special class for women who sit there and learn what the risks are of them having a baby in an obstetric unit versus a midwifery-led unit, i.e. for a woman who's low risk, uncomplicated pregnancy and previous birth experience, they are actively promoting the fact that it's actually safer to have your baby in the midwifery-led unit. So it's starting, if you like, it's a big ship trying to turn, but explain to women being within a delivery suite environment when they have an uncomplicated pregnancy and labour is probably more risky to them. So if you look at Europe, including the UK, you'll find that most births, as Christina was saying, are in hospital. They're not even in midwifery-led units. They're very much within the consultant-led labour wards. We've got very routine intrapartum practices that, if we work in hospitals, we're very all aware of, that don't necessarily benefit the mum and the baby. Electronic fetal monitoring is used widely. I've even seen it used within midwifery-led units and sort of labelled as that's normal. We also see quite wide use of artificial rupture of membranes and the rates of epidural use. And I'm certainly not against epidural, yes, sir. It's just that sometimes the women can cope, if you like, without an epidural, but they do need the support of a very good midwife. It's really hard, I think, when you've become used to a type of way of working and a culture that doesn't actually support physiological birth. I think staff are afraid, women are afraid, and that's really why you do need posts like the consultant midwife post, particularly around normality, because midwives need support. It's very easy, I think, to be critical in hindsight, and often we are when things don't go quite to plan, and also helping in the planning of women's care. It really does need someone who can stand up, know the evidence and support the midwives and make sure care is safe outside those consultant-led labour wards. De-skilling of midwives, again, it's not everyone's choice to work in a midwifery-led unit. I don't think sometimes midwives actually have the skills to provide that type of care. Whether we like it or not, that's meant to be our area of expertise, but I don't think it is always. So there's a lot around practice experience, support and training of midwives. And of course the litigation angle as well has really influenced probably how babies are born now. women's views are so important and so key, but you find that what was considered by the professionals looking after them to be quite minor interventions, things like ARM, episiotomy, urinary catheterization, were really not regarded as particularly horrible things to do to women, but actually the women themselves found them as upsetting and traumatizing as maybe having a forceps delivery. So we underestimate, I think, the effect of what we do to women when we're looking after them in labour. And we really don't talk about that very much. And what also you find is that it didn't have that major impact on the well-being of the mum or the baby either. So it's trying to make sure that the women that don't need the intervention are appropriately selected, as opposed to the vast majority, and the vast majority are giving birth in consultant-led labour wards, are actually having things done to them that they really didn't need. So it's having the confidence to know when you do need to do something, but also when you don't need to do something. We're very good at trying to treat pathologies, i.e. what is the risk factor, what could go wrong for this woman, but we don't always recognise the actual birth experience for women and how that has an effect on them. And sometimes you'll find that the women who do perhaps want something a little bit different, or they're not happy with the type of advice that they've been given about how they should give birth to their babies, they're sometimes labelled as quite difficult patients, as opposed to someone who perhaps doesn't want something that goes down that route of medical intervention. We've got the evidence there now. Most of you hopefully have heard about the birthplace study from 2011, a huge study looking at women who had low risk or normal pregnancies and previous labours, where they birthed and the birth outcomes. So we know that women who have a low risk pregnancy, it is very safe to have their baby within an alongside birth centre, a freestanding birth centre, or at home. It is safe. But what we actually see is that for particularly women who've had a baby before, there really isn't any significant difference whether they have their baby at home or in the consultant-led unit. The outcomes are the same. So we should really be telling women this, and this is the sort of stuff that's coming out at Barnet and the Portsmouth app that I mentioned that you can Google, I think. They're trying to get that information out to women. Women who are having their first baby, you probably know that the evidence showed that there probably was a marginally and a slightly increased chance of them having higher perinatal and maternal morbidity if they birthed at home, and a 45% transfer rate. So for those women at home, they were very likely to be transferred into hospital, but a marginal increased chance of complications for them or the baby. But for women having their second or subsequent baby, there really wasn't any difference, and the transfer rate was 10 to 12%, so much, much lower. I think this is something I rarely have heard said, is that women who have had babies before, when it's been uncomplicated, have got a substantially lower chance of having a caesarean section if they aren't on a consultant-led labour ward. So that's quite a different statistic there. They're more likely to have a caesarean section just because they're within a labour ward environment. So to sum that up really, women are more likely to have a normal birth if they plan their birth outside of an obstetric unit. We're talking about low-risk women here, not the women who have more complicated pregnancies. They're less likely to have a caesarean section, less likely to need an instrumental delivery, fewer medical interventions, and actually one thing that is so key is that their birth experience tends to be reported as more positive. And that's a picture of one of the mums at Croydon who had her baby about a year ago now, second baby, very straightforward. She chose to have the baby in the alongside birth centre, and again without any complications. The evidence that we have, without going over it too much because there's lots of evidence, we actually use it. For example, the NICE guidance, we use a lot of evidence, but it's not actually often very good evidence. It's not very good quality evidence, and yet we quote it and speak it all the time. So you can actually find that what we're doing isn't very good evidence-based practice. What you find as well, and we're all aware of it, we're battling with the media and how media portrays childbirth. And it's interesting that I was at the launch of the birthplace study when it came out, sort of sat in the audience really, and I remember the headlines of the newspapers on the day. It was all about the risk to women having home birth. That's all that really showed. It didn't show anything at all about the fact that if women who had uncomplicated pregnancies or had laboured well before had a very high chance of having less intervention and poor outcomes within the midwifery-led areas. That didn't get publicity at all. It was all about the risk to home birth. And then just other examples really. 75 female obstetricians asked in London would they choose a planned caesarean section. 31% of those said they would choose it. That got lots of publicity. You know, doctors who look after women having babies want cesarean sections. At a very similar time, a survey of midwives asked the same question. 96% said they wouldn't choose a planned cesarean section. And again, some more obstetricians up in Scotland, 77% said they wouldn't choose a planned cesarean section. That didn't get any media coverage at all. It's not newsworthy. And that's what women see out there. That's what scares them. I was going to show you one of my least favourite programmes, One Born Every Minute. It really petrifies women. I sort of still slightly disappointed that, you know, I've heard midwives say, oh, isn't that quite fun? It's not fun. It's actually a way of terrifying women into how to have a baby. The one I was going to show you, it literally shows staff running around, obviously responding to emergency, but it looks like a war zone. And I know it's cut and edited and all the rest of it, but if you were about to have a baby, that is going to petrify you. I did used to run a little clinic at Epsom for women who wanted a cesarean section through maternal choice. I'd always ask them, have you seen that? They've all seen it, and they can all look as terrified as I would be if I had to have a baby after watching that. So it's about trying to get the message out to women as well within our local units that childbirth is safe, and actually it doesn't need to be that you feel like you're about to go into some war zone when you go into a hospital. So how do we actually help women have normal births? And the key probably is in the midwifery-led care within models of care where the women have had care from midwives. And again, we're talking about low-risk care here. So we know that those women who had midwifery-led care are less likely to need to be in hospital antenatally for whatever reason, less likely to need spinal and epidural analgesia, less likely to need an episiotomy, less likely to need forceps and Von-2s, and less likely, and this is really interesting, to lose their baby before 24 weeks gestation, just because they had continuity of midwifery-led care. And I know Jane Sandel, through some research coming out in London, is wanting to look at the same thing for women who have more complicated pregnancies, whether they have continuity of midwifery care. Is that going to help stop them having preterm babies or babies less than 24 weeks? So that's looking at it from a different perspective. What we know is that, as I said already, women are more likely to have normal births, but they're also more likely to be very much more satisfied and know their midwife. So there is the evidence there, but we still seem to be in this state of really having the normal place for women to have their babies is within a consultant-led delivery suite. And we've all worked on our birth centre environments within the sector. That's one of Croydon's rooms, which was refurbished recently. And it's just trying to create, as best as possible, a non-medical environment. I find it, I won't say interesting, worrying, if you like, when you go in some of the birth centres and you still see a typical delivery suite bed with a lithotomy stirrups very visible, and it's still creating the labelled environment within the midwifery-led areas. This is a document which is quite succinct and easy to follow. It's written by the RCM, the RCOG and NCT, and it really outlines what is it that increases normal birth rates. And we know all this, but we do struggle sometimes to achieve this. The one-to-one support in labour, we on paper say that we achieve it, but it's the quality of that one-to-one support in labour. And a midwife, again in Scotland, had done some work for a PhD. She wanted to know what goes on in the birthing room when the midwife's with that woman in a delivery suite setting. What did the midwives do? And she found that the midwives who stayed with the woman in the room, positively interacted with them, were interested in the woman and her family. They tended to be nicer people, but they actually found that those women who were with those midwives achieved a normal birth. And we don't really say this very much, I don't think, within midwifery. And she found as well, the reason she did her research, because you get some midwives saying, oh, I don't know why, but the women I look after always seem to end up with an instrumental delivery. Water, again, it's something that seems a bit weird, and I know it's still quite a new concept for some people, but the fact that you're in a warm environment within the water helps women feel a lot more relaxed on its own. And actually, I think there's an element that they feel quite safe because they're a bit more protected by the pool and the water. If women have a low-risk pregnancy and labour, that they plan their care within a midwifery-led setting. We can't really achieve this. I think you only achieve it in some case loading models that they know their midwives. And the junior doctors, and by that we mean the registrars, who actually we don't always treat as junior doctors, but they're still in training, really having good skills in terms of helping women achieve that normal birth. posts like mine, which is focusing on normality and being a bit clever, I think, about how those posts are funded, because the commissioners as well, I think I'm right in saying, and my post is very much from a commissioning perspective and a sequin, so that's where my post has come from at Croydon. And of course, we need the support of the consultant obstetricians. And everyone will be different in their practice, like the midwives will be different, the obstetricians are different. But I think Christina alluded to the fact that at Croydon there is a higher normal birth rate. And you can see that because we're a bit incestuous midwives. We do travel around the sector working. There is a different culture sometimes about how women achieve that normal birth. Having a shared positive attitude is probably actually one of the key things when you're within a delivery suite environment particularly, and having that positive leadership. So I sometimes feel like I have to protect midwives when they've done their best to help someone achieve a normal birth and they get criticised at times. Evidence-based practice, like I say, but one of the key things as well is how the team works together. Does the obstetric midwifery team actually have good communication? Do they get on and do they respect each other? And that's vice versa. What I thought was really important was for women who've had birth experiences to perhaps speak to us today. And we work day in, day out, for those of us that are midwives and obstetricians or anaesthetists, with women every day. But what doesn't get mentioned very much is actually what was it really, really like for them. And women go away and maybe you see them a year or 18 months later and they are really traumatised from what happened to them. And often it was just the things that we think are the simple things went wrong, and I'm talking about people having good manners and being polite and listening to women. It's not complicated, but actually at the time they just felt they felt abused during that experience. So the qualitative research that we know about hardly gets mentioned within childbirth. It's all about the quantitative data, where you're looking at your randomised controlled trials. That doesn't show women's experiences. What we do know is that normal birth has a very positive effect on women. And if it's given in the context of women feeling very cared for and supported, it has very long-term positive consequences, and for their physical and their mental health as well.